This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub Podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Elara. Today we're looking at a fascinating new study from World Neurosurgery 2026 titled Functional Outcomes After Resection of Middle Frontal Gyrus versus Superior Frontal Gyrus Tumors.
This is a topic that hits home for anyone who spends time in the clinic. One of the hardest parts of our job is preoperative counseling. When a patient comes in with a frontal lobe mass, they want to know exactly what their life will look like the day after surgery.
Exactly. And as the paper points out, we are often at a disadvantage because neurosurgical oncology outcomes are heavily influenced by histological factors, things like molecular markers or tumor grade, that we simply don't have access to before we actually get into the OR and send tissue to pathology.
Right. We're looking at an MRI, and while we can guess, we don't know the histology. This study argues that we should lean more heavily on anatomically tailored outcome data. It's about using the maps we have, specifically the middle frontal gyrus, or MFG, versus the superior frontal gyrus, the SFG, to predict surgical risks.
The researchers specifically wanted to compare the incidence of supplementary motor area syndrome, SMA syndrome, and other postoperative outcomes between these two anatomical sites. For the residents listening, the SMA is located in the posterior part of the SFG, so the anatomical distinction here is critical.
It really is. Let's dive into why they chose these two regions. The SFG and MFG make up a massive portion of the prefrontal and premotor cortex. When we resect tumors in the SFG, we are often flirting with that medial wall and the SMA. Dr. Elara, how did the paper describe the complicating factors of preoperative counseling here?
The paper emphasizes that because we lack histology, our risk assessment is often too general. By shifting the focus to anatomically tailored data, we can provide a more nuanced prognosis. In this study, they looked specifically at how the resection of the SFG versus the MFG impacted the patient's functional recovery.
And the big player here is SMA syndrome. We've all seen it. A patient wakes up with a significant hemiparesis or even total mutism, and it's terrifying for the family. Even though we know it's usually transient, being able to predict its likelihood based on whether the tumor is in the SFG or the MFG is a huge clinical advantage.
Precisely. The study aimed to see if the incidence of this syndrome was significantly higher in one gyrus over the other. Given the SFG's proximity to the medial motor structures, the data showed that the anatomical location was a powerful predictor of these postoperative functional deficits.
It makes sense. If you're in the middle frontal gyrus, you're often more lateral. You might be worried about the frontal eye fields or executive function, or perhaps language if you're in the dominant hemisphere. But the classic SMA syndrome is really the hallmark risk of the SFG.
And that's the predictive value the authors are talking about. If we can tell a patient, because your tumor is in the superior frontal gyrus, there is a specific X% higher risk of temporary motor inhibition, that is far more valuable than a generic talk about brain surgery risks.
It also shifts how we plan our surgical approach. If the data shows a higher incidence of SMA syndrome in SFG resections, it might influence how aggressively we pursue a gross total resection near the medial bank, or how we utilize intraoperative mapping.
The paper concludes that these anatomically tailored outcomes are essential. They bridge the gap created by the lack of preoperative histology. We might not know the IHC or the 1P19Q status yet, but we know exactly where the tumor is sitting.
It's a return to neuroanatomical fundamentals. It's about respecting the boundaries of the SFG and MFG and understanding that frontal lobe is too broad a term when we're talking about functional outcomes.
Definitely. It's a great reminder for residents that surgical planning starts with a deep dive into the cortical anatomy on that T1 weighted image.
Well, that's a wrap for this episode. A big thank you to the authors of this study for giving us more data to bring to the bedside.
Thanks for listening to the Neurosurgery Hub Podcast. We'll see you next time.